Okay. So everybody can see the PowerPoint. So trauma assumed care. And you may have heard the language of trauma informed care before, which is great. I heard Dr. Greg Hanley say the first person I heard say it in this way, trauma assumed care. And that really, I like, which sounds weird, right? I like something related to trauma, but I like that language because I think trauma informed means that we're, if we know about that there's trauma, then we might do something different. But I think trauma assumed care means that we are assuming that anybody we come in contact with has a potential trauma history. And that, for me, tends to translate to practice that we are always engaging in a way that assumes a person has had trauma, which means we are always doing some of these strategies as part of our baseline or regular repertoire, not just when somebody discloses that they've had a trauma or that we learn from their history that they've had a trauma. So I want to start by just sort of labeling trauma. So I am a psychologist as well as a BCBA, and most of my training around trauma came from being a psychologist. I actually do a lot of work in the area of individuals who've experienced what's often called little t trauma and big T trauma. So big T trauma is often like a major traumatic incident that we would all consider traumatic, like somebody being killed in front of you or surviving a hurricane. Little t trauma might be things that you might not consider traumatic, but somebody else might. And really, trauma is a psychological and emotional response to an event or experience that is deeply distressing or disturbing. So you notice there's not a list of what is and isn't trauma, because trauma is about our perception of the event. There's something that might be traumatic to me that might not be to you. If I felt unsafe and that my life was in danger, it's trauma, even if it isn't for you. So perception is reality in all things, but in this specifically. So how many people have seen this picture here on the right where it's both a young woman and an old lady? Yes. Can everybody see, can anybody see both? So here is the old woman's nose and her kind of, this is covered, and here's her like front of her hat and her coat. But for the young woman, here's her jawline and her fancy hat, just kind of looking over her shoulder. And this might be her voluptuous, voluminous, maybe more than voluptuous hair. It's interesting, right? So Kate's talking, she sees one first. I usually do too. And it's kind of a mental exercise to switch back and forth. Sometimes on these, I can't see the other one until someone shows me. That's okay. When someone feels intensely threatened by the event that they witness or experience, and I think that's important too. A trauma can happen to me by witnessing something that somebody else goes through. It doesn't just have to happen to me. And again, it's our perception of the event. There's a variety of different types of trauma. This is not an exhaustive list, which means there are things that could be traumatic that are not on this list, and these are the common ones. Bullying, complex trauma, which basically means multiple traumas over time, so not one event. Community violence. There's been a lot of this with the focus on racial equity. Disasters. Early childhood trauma, generally we think of that in the very early, like before school, right? Before they head to school, maybe before 3, before 4, birth to 3, birth to 4. Intimate partner violence used to be called domestic violence. Some people still say that, but folks use that language more common now. Intimate partner violence. Medical trauma. This is one I do a good bit of work with moms or folks with chronic health conditions. I think I've shared in this group, but I shared pretty openly that I have multiple sclerosis, and there can be trauma associated with the treatment, or doctor's appointments, right? Medical trauma is a real thing. Physical abuse, refugee trauma, sexual abuse, sex trafficking, terrorism and violence, traumatic grief. So the difference between maybe traumatic grief and grief might be subtle, but it can be a trauma, depending who is the deceased and maybe how they died. Are there any types of trauma that you would add to this list? It's okay if not. Sometimes folks often think of the physical abuse, sexual abuse, and neglect as trauma. And maybe we don't think of some of the other ones, right? Bullying can be traumatic. I live here in southeastern North Carolina, so we have hurricanes. And in, let's see, it's 2021. So maybe 3 years ago, we had Hurricane Florence here. And it wasn't even a high category. I think it might have been a 1 or a 2, but it devastated our area. It destroyed our clinic. Our clinic at that time, 7 inches of water came in and flooded, and everything was destroyed. Everything. I mean, some stuff's plastic, but mats, right? So inside the mat is like foam. You can't possibly get that clean, in my mind, to like protect people from the mold. Papers were destroyed, and it caused somewhat of a trauma response. Like, we had nothing, and our families needed services, and I wanted to take care of my staff, and it was scary. Heard that toxic workplaces. Yeah, so that's a great, Erin's talking about really kind of what we're talking about is burnout, and that can be a trauma. If you feel that your life is in danger and you feel unsafe, that could be trauma. And I also think what Erin and Amanda might be talking about too is that there are symptoms or responses that might be called trauma responses that do not occur only for trauma. So if a person has which we'll talk about in a little bit, so somebody who has an anxiety disorder, the symptoms or the behaviors they engage in are also indicators of trauma. So it's kind of a Venn diagram, right? Like there are overlapping symptoms between a trauma disorder, anxiety, and burnout could go into that, because often with burnout, there's anxiety and depression. So some of those symptoms can be the same, and a workplace could be traumatic if it's very unsafe. And safety is physical safety, so, or psychological safety. We interviewed an RBT who really, I think, experienced trauma in her last position because of the high intensity and frequency of the physical aggression directed towards her. Okay. So trauma could occur to anyone, right? Because the only thing constant is change, and things are unpredictable. There are populations that are at greater risk for experiencing a trauma. Substance use and abuse, so folks who are using substances, individuals who are under significant or really economic stress, military and veteran families, those with intellectual and developmental disabilities, individuals who are homeless, and LGBTQIA+ individuals. So kind of pause and look. You're welcome to use the chat, and you don't have to. If you or me, right, do we fall in any of these categories? Do we serve anybody in these categories? And it touches on intersectionality, right? So I might fall into multiple of these. So maybe I am a veteran who is disabled, right? So I was medically discharged, and that led to economic distress, and that led to substance use and abuse. So boom, that's a 3-fold increase. This does not mean that if you fall into one of these categories, you will or have experienced trauma, and it's correlation, right? Correlation, not causation. We know that folks in these categories are more likely to experience one or more traumatic events. There's also something called secondary trauma. And this is indirect exposure to trauma either through a firsthand account or a narrative. So I am a psychologist and I work with individuals who are trauma survivors. I also am a trauma survivor. I'm actually a complex trauma survivor. And which is part of why I do work with trauma, right? Because I know how much it can impact you and how life-changing therapy can be. And because I am a complex trauma survivor, I work to be very thoughtful about how many patients I'm working with trauma. So an indirect exposure could be that I see it. I see we've seen a lot of those recorded videos of individuals recording racially motivated events that have been violent, right? So violence against Black and Brown individuals. If I'm there recording that video, that could be an indirect exposure. So a firsthand account, I'm seeing it happen. If I think about it in our clinical setting, so we work with mostly for the ABA side, we work mostly with pediatric patients with autism and related disabilities. So let's say one of the children is having a very large maladaptive behavior. We don't do restraints, but let's say we did, right? Let's say I am a child receiving ABA and I see another child who's also receiving ABA get restrained. That might be traumatic. Maybe I'm worried that that could happen to me. It could also be traumatic for the individual. You don't have to answer in the chat. Think about if you've ever been restrained. And if you haven't, try to imagine what that's like. It's horrible, right? Somebody who's larger than you, maybe two people, maybe three people are controlling your body when you feel so out of control internally. It's scary. You're in fight or flight. You can't process, you can't reason. And then, or through a narrative, so somebody telling us about the trauma, and that is generally, so for mental health clinicians, that can be a concern, that hearing trauma and trauma stories all day can lead to secondary trauma. And I see in the chat, I apologize for missing that, I forget about military families. So I think that's a great example that we think about sometimes when we're a member of one of these groups. Oops, how do I go back? Or if we are a trauma survivor, we can forget that that might be different for other folks, right? We are here at Camp Lejeune, New River Air Station and Cherry Point. And so I forget what it's like to not be surrounded by military families. I almost forget what it's like to actually be a civilian living in a civilian city that exists without a base, because we've been here for 5 years, and before here we were at Pendleton, and before that we were in San Diego, which is a little bit more like that, but I was still serving military connected families. And so because we are part of that, we forget. Traumatic for your daughter with ASD. Yeah. So it can be traumatic seeing your daughter go through trauma, or anybody really. We have a family, let's say that one of the kids was hurt somewhere. Knowing that your child was hurt, particularly if they have a disability, can lead to symptoms of PTSD, right? Or just maybe not even PTSD, but maybe, but can sort of fall into that secondary trauma, because someone you care about more than kind of anything was in danger and you were out of control. That control piece is key for trauma, because I can't think of a trauma experience or event where the individual experiencing it has control. That's part of what makes you think your life is in danger, is because you have no control. I also, maybe this is a good time to pause. I know I have some breaks throughout here because we're talking about trauma. Maybe you know somebody who has experienced trauma. Let's also not say traumatized, right? Because that a person experiences trauma creates a little distance from it. Let's not use the language of victim either. I like to say survivors of trauma. Of course, you can always ask folks what they prefer, but language is powerful. And if you need to pause, do that. If you need to mute me, do that. You can always come back and watch it later. If you need to engage in some grounding, which is a great strategy when you're feeling, I think we talked about it during our health and wellness self-care one, but things like, so I've got water here, mainly because I'm on a new medicine that makes me super thirsty, but taking a drink of cold water or a warm drink, right? Noticing that sensation gets you out of your mind and back in your body. When we are re-experiencing or feeling anxious and stressed, or really any big emotion, it's here where our thoughts are going. And we want to get back in our body to remind ourselves that I'm here in this moment and I'm safe. Even if I'm talking about a trauma that I've experienced, it's not happening in this moment, and talking about it can make me feel like it is, because those feelings come back in a sensory way, and I can, in this moment, I'm safe. And grounding can be, a sensory activating your senses, smelling something, drinking something. It also can be noticing your environment. So grounding is noticing maybe 5 things I can touch. So I can touch the table under here, and I feel my feet. I'm all of 5'2", so my feet don't totally touch flat, but I can feel my toes touching the rung of the bar stool, like the high chair I'm on. I can feel my butt against the chair and the chair back against my lower back. I'm in my body. I can smell the mac and cheese that I made. I can smell Lysol from cleaning. I can sort of smell the bagels that were cooked earlier. We have breakfast together on Saturdays. Get back in your environment, because in this space, you are safe. That works anytime you notice your mind kind of as a runaway train. I'm wondering what systems or programs are in place at your job or in your life to help move through potential secondary trauma. I can talk about a little bit of the things that we have here at Del Mar, but I also think you might wonder why I'm asking, or maybe I'm not experiencing trauma. Well, I hope you aren't. And even if it's not trauma, it can be stress, right? Remember, we're in our self-care and wellness and community care webinar. I was talking about sort of some of the risk factors, and unpredictable patient behaviors can be at risk. And so that can increase our anxiety. So even if it's not trauma, what is in place at your job to help you move through some of those difficult emotions and feelings that, if not addressed, could move into sort of those stored feelings? Particularly when it's our job, we can't talk about our job outside of our job because of HIPAA, or if you're in the school district, or in the educational setting, we still have privacy and confidentiality practices. And so we do roundtables once a month, maybe or as often as needed, but at least once a month. And maybe you've heard them on one of the podcast episodes, or I talk about them regularly, where RBTs get together to support each other, not through trauma. That shit should be addressed far earlier than that. But we have these kind of ongoing where people can get together. We have a robust EAP, or employee assistance program, where people can access counselors 24/7 at no charge. If there is something large, like I see folks talking about debriefing, which is kind of talking about the event afterwards with somebody who can hold space for you. Hold space means I'm really just listening and creating space for you to feel your feelings, which is great. And if you're doing that a lot for people, holding space for their feelings, make sure you're getting somebody to hold your feelings. As a psychologist, I have my own therapist, right? I hold a lot of feelings, and then I, need somebody to help me hold my feelings. Provide support at personal events. Yep. An MFT on site, mindfulness classes, supportive supervisors. This is excellent. You'll see, I think next week, Liz Stawicki, who's one of our, she's been a senior RBT with us. She's going to talk about peer support. Because I think it's great when supervisors are supportive. I certainly hope I'm supportive to our staff, and I cannot forget my stimulus value is I am a boss and a supervisor. And so sometimes they may be less likely to fully process with me as they would with somebody else. And so we want to make sure that they've got multiple levels of support. And I see you all mentioning that. I'm really glad to hear that. What is the company protocol as to how to respond if a client expresses a traumatic event or demonstrates symptoms of trauma? Sometimes I think this is happening more, and we'll talk a little bit about other ways that we can practice trauma-assumed care. But I think this is just thinking about what already exists. Maybe we have some, and that's great. And maybe we don't, that's okay too. It's the beginning of a conversation about what we can do. And even if it's not at work, making sure that you have these in your world. So for us, a lot of times, if somebody discloses a traumatic event as a licensed psychologist, I immediately get involved. We also make referrals to other mental health clinicians. We keep a fairly solid referral list for outside of our organization if we're full. And then we talk about trauma with our RBTs and BCBAs, our ABA team, who may be less well versed in trauma, not because they're not wonderful, it just isn't generally part of the training. And then, making sure that we're normalizing help-seeking behaviors for us as staff. So the impact of trauma. Spoiler alert, it can impact all areas, and it can impact multiple areas, right? It can impact all of these as well as one or two. The emotional impact can include dysregulation, sometimes called lability, these really high highs and low lows and very little middle ground. It's exhausting. Going from super up to super down and up and down, that spends a lot of energy. Sometimes we feel too much or too little, right? So every little thing might feel really big, or we avoid any feelings at all, which is often called numbing. That is more likely to occur when trauma occurs at a younger age, that numbing piece. Because your little brain's not developed yet, and you don't know how to make sense of it, and so we just avoid. Which is adaptive in that moment, because you don't know what else to do, but it'll turn maladaptive if we don't work through it. Cognitive, so intrusive thoughts, so remembering the trauma just feels like out of nowhere, or worrying something bad's going to happen. Excessive or inappropriate guilt, cognitive errors. So this happens, let's say I'm involved in a trauma that includes a weapon. Anytime somebody goes to pull something out of their coat or pocket, I might believe that that's a weapon, right? That's a cognitive error based on my learning history. And let me frame this behavior analytically in case I've not made that really overt. Really, a trauma is a learning history that was so damn punishing that it continues to impact the current experience in a really undesirable way, in a really uncomfortable way. Idealization, so thinking things could be better. Not like in a hope way, but that the person wasn't that bad that did this to me. That happens a lot when it's a parent or caregiver that engaged in the trauma. Executive function impairment, so having a hard time concentrating, inhibiting, planning, organizing. Social impact, this can be big. It just really impacts your relationships with others in so many ways, because generally trauma occurs in a relationship. There is another human involved a lot of times. Not always, right? There could be a wild animal attack or a hurricane, and a lot of trauma occurs in the context of another person. This can be particularly challenging for individuals with autism, or let's say social anxiety, or other pre-existing diagnoses that are already associated with difficulties engaging with others. Relationships can also serve as a protective factor. So if or when a person experiences a trauma, if they have a strong social support, that will help them work through that trauma in a more healthy way, more quickly. And part of the recovery process, or working through, I can't believe I used recovery, I hate that, because it never totally goes away. It becomes part of who you are, and it doesn't dictate everything that you do. Part of that moving through process includes developing strong, healthy, and safe relationships. Or even if we think about, like in the context of the hurricane, I will never forget how some of our RBTs came in to help clean up. They didn't have to. I felt so alone. And they were like, Dr. Becca, we'll be there. How can we help? I thought, what? That was really part of the healing for me. The most powerful. And then of course therapy, right? Physical, so somatic complaints. That means that you feel your emotional symptoms in your body. It's very normal, particularly in younger kids. They'll complain of stomach aches, headaches, their backs can be sore. How that happens to me from like, I hunch like this when I get, my shoulders are up, I'm like tense, jaw pain from clenching my jaw, right? We can really feel the distress physically. And if that distress was huge, which trauma is, right? If it's trauma, it was a big distress. We feel it big in our bodies. Hyperarousal, so being always up. I'm constantly scanning my surroundings for trauma or for scary things. Any change I interpret as scary. My heart beats more. I maybe don't digest food as well, right? These are the things that happen. We're in that fight or flight response. I'm not meant to live there. Very jumpy, right? If any of the Del Mar folks are online, I mean, like I'll come down the stairs or something. I just am easily jumpy. It's not just trauma, it's sort of anxiety as well. Neurological, cardiovascular, gastrointestinal, respiratory, musculoskeletal, and dermatological. Kind of all of our systems in our body can be impacted. And then sleep disturbances. And it's not just sleeping less, because sometimes folks sleep more as part of that numbing or avoiding. Behavioral, so reenactment. Sometimes we try to do the same thing that we did that led to the trauma to create something different, a different outcome. Self-harm. This can be cutting, burning ourselves, head hitting, right? Self-destructive behaviors. That can be over drinking, over using substances that are either illegal or prescribed medication. Avoidance, avoiding anything that reminds us of that trauma. One of the traumas I experienced included animal abuse, and that animal that was abused, I couldn't look at that type of, it was actually a pug. I couldn't look at pugs forever. And if you know anything about me, like, damn, Dr. Becca, you do everything with pugs. I do now. Not only do I love their little faces and personalities, but it's a reminder that I can do hard things and that we can recondition. So just like pugs in that moment became a conditioned punisher and were terrifying to me and upsetting, we can recondition them. And through working through that trauma, I was able to love them again. And part of loving them is because it's a reminder that I can do hard things. And I mean, who would think that pugs could be a trigger? Probably no one, right? Their little clown faces and curly pigtails. And they were for me. And so that's why trauma assumed care is so important, because you just don't know what could be a trigger for someone. And then substances, and then developmental. So neurobiological impact. So basically, there is a disruption of the neurotransmitters that impact neural growth. And this happens particularly in young kids. So if the trauma occurs when they're very young and their brains are still really developing, trauma early on can disrupt that growth that can last throughout life. I read this article where they could check, particularly, so this adverse brain development. So that oxytocin, so it's like a feel good, safe, love chemical. And in women who experienced a trauma when they were young, when they checked their oxytocin levels into adulthood, they were still lower than those who did not experience trauma. This is biological. This is not saying, and now it doesn't happen for everyone, but it can. And so this is not set. It's like saying, make more insulin to somebody with diabetes and expect their pancreas to make more insulin. Telling a person who is a trauma survivor to get over it ain't gonna work. It's not. And imagine if it's an individual who's really young, their frontal lobe hasn't developed, so their language isn't strong, so they can't even begin to process or make sense of what happened. Cortisol is our stress hormone, and catecholamine. So these are just different chemicals in our brain and body that impact how our body functions, and trauma changes how our brain and body operate. And that's what leads to some of these, like gastrointestinal, you're always nervous or anxious and you probably have diarrhea or constipation, or you're only eating certain foods. Respiratory, you take these deep sort of like, or not deep, shallow breaths. which actually can make you lightheaded, right? If we're going to do deep breathing, we're going to do belly breaths, which is inhale through your belly, puff it out, right? So as you're inhaling through your nose, you want to fill your belly with air and then exhale. For kids, I talk about you can lay on the floor and put a stuffy or something on their belly so that as they inhale, you have them expand their belly and try to knock the animal off or the stuffy off. Any questions about these? And also just a general check-in about how we're doing. Your anxiety shows up in digestion. Yeah, same. It's common. And I want to be sure that when I'm talking about anxiety can be a symptom of trauma, but experiencing anxiety does not mean that we experienced trauma. Does that make sense? Like, yes, I love that you're noticing these, and I want to be clear that I'm not saying that if you experience that means you had trauma, and it might give us some insight into how somebody who experienced trauma might feel, because there could be some similarities. Okay. There are different responses to trauma. Fight and flight, people usually know. Freeze, I think people know more, and fawn, generally folks don't know. So a response to trauma, you've got these two nervous systems in your autonomic nervous system, right? Auto, it's automatic. We've got our sympathetic and our parasympathetic. Our sympathetic system reacts to danger. Fight, flight, freeze, or fawn. That's our sympathetic. Our blood rushes to our extremities. We stop digesting food. We breathe different, like we're running. Cortisol comes flushing out. We are ready to keep ourselves safe and do whatever to keep ourselves safe. We're not meant to be in that place for a long time. That should function till we're safe. Then our parasympathetic, right? Remember, parachute opens and slows you down. That should kick in automatically when we're safe to bring our body back to a baseline or closer to baseline. Sometimes after a trauma, our sympathetic nervous system kicks in, even though the trauma is not happening. So we're constantly or more regularly going into this sympathetic activation, even when we're safe. So then our brain is telling you you're not safe. And you're part of what makes all of this happen is that flood of sympathetic nervous system activation often. And sometimes it happens so much that the parasympathetic nervous system stops responding or responding as well. And so you stay in this activated state. So fight is exactly what you think. I'm gonna fight. Flight, I'm gonna run away from the danger. Freeze, I can't move at all. Fawn is joining with your abuser or joining with the trauma. So if somebody has experienced abuse, they may fall in love, right, with the person or feel that they're falling in love. They're going to do whatever the person says. How can I help you? You're right. I'm awful. I deserve this, right? You join with the abuser or the abuse. This one all can be associated with guilt. This one folks tend to have a lot more guilt with. I want to be clear that there is no right, there is no wrong way to respond to trauma. Whatever you do that keeps you alive means you did the right thing. If you are in danger, no matter how you responded, it was the right thing because you're still here. A lot of times people will say, I wish I had done ... or I should have done, or I shouldn't have done. You are here. Retraumatization occurs, and this is important. So we kind of talked a little bit about, let me stop. Any questions about what trauma is, our responses to it before we get into kind of what we can do a little bit differently and how it might look for us? I also notice even talking about trauma, my voice is slower and lower as an attempt, subconsciously really, to counteract some of the content that we're talking about. So retraumatization is any situation or environment that resembles the trauma either literally or symbolically. that basically triggers those difficult feelings and reactions associated with the original trauma. So like I mentioned, pugs used to be for me, black pugs specifically. They would be a trigger that it would make me think of the trauma, and then I would go spiraling down, either replaying it in my mind or worrying it was going to happen again. That's a pretty concrete example, right? A pug was involved in the traumatic events. When I saw pugs, it was traumatic. There's other things like smells that you may not realize until you smell it and you are like, oh God, where'd that come from? Food, feelings in your body. I think around 4th of July, you might hear a lot about being thoughtful about fireworks, because that can be triggering for combat veterans, or really anybody whose trauma or life experience included sounds like that, even though it's not the firework, it's the sound, right? That's almost that symbol, that symbolic. Yeah. And it occurs unintentionally most times. Somebody showing me a pug puppy would have no idea what that would do. Or we think about fireworks, and that, is this celebratory time. It's unintentional. And that's why I like this trauma assumed conceptualization, because it assumes it could happen unintentionally. And so we got to be looking at everything that we're doing as a potential trauma trigger. It can occur anywhere and across any sense. So smells, sight, sound, touch. If we think about within a systemic, sort of our system of operating as clinicians, as a therapist, so sometimes having to continue retell their story could be re-traumatizing. So we want to avoid that as much as possible. They have to retell, we need the info, and let's say a patient discloses a trauma to you all, they might have to tell the story a bunch of times. We want to minimize that as much as possible. We don't want them being treated as a number, right? Sometimes when you experience a trauma, you're often not treated as a human, you're seen as less than human. And so anytime that an individual is treated as just another number in the line, that can come up. Procedures that can require disrobing. So we help potty trained kids here. If they experienced a trauma, pulling down their pants in the presence of somebody else could be a potential re-traumatization. And being seen as a label. So being autistic, being having PTSD, right? These, we are all humans, and none of us experience things the same way. No choice in service or treatment. That's important. We serve a lot of pediatrics, so they have to come here, right, as per parent. And are there ways that we can give them choice while they're here? No opportunity to give feedback about their experience in service delivery. And so for older kids, we're often asking regularly, how's this going for you? How's this feel for you? We quarterly send out feedback forms to parents. And then in relationships, so trust violation, non-collaborative, right? We want them to be involved in their treatment process, use of punitive treatment, coercive practices, or oppressive language. This, I think, is a big one that happens unintentionally. Punishment, every punishment practice could potentially be a trigger of when the ultimate punishment occurred, which was the trauma. So being thoughtful of these things. I wanted to talk about triggers because I think we hear that language a lot. And so triggers, there's different types of triggers. It could be a state of being. So when I'm tired, I'm more likely to be triggered. So being tired can trigger bigger emotions. Being hungry can trigger bigger emotions, right? Because I'm not at my best. And I always remember hungry, angry, lonely, tired, HALT. Love a good acronym, right? That helps us remember when we're not at our best and when we want to be gentle with ourselves and those around us. Hungry, angry, lonely, tired. It also could be an item, right? A pug, maybe kids who've been engaging in self-injurious behaviors may have had somebody use a block pad. How do I call those differently? Like it goes across your elbow and it's it's padded. So maybe anytime they see one of those come out, they get triggered and they go even bigger, right? Their behavior gets even bigger, not less, because they feel even more unsafe about what could potentially happen. Smells, again, could be triggers. Maybe they had a staff member who worked with them who engaged in more physical prompting or restraints. There was always the same staff member, let's say, involved in the restraint practices, and she wore a perfume or had a specific smell on her. Not like a stink smell, it could be stink, but it could be a pleasant smell that becomes a trigger for these big emotional reactions. Related but not so, I just got a bunch of the Bath and Body Works like fall and like holiday scents came out, and we've got a fabulous team here, so I bought a bunch of them so that staff could pick one out so they can engage in greater self-care when they're washing their hands, right? Slow down, notice the smells, how it feels, and a reminder that they're cared about here, right? So you can pair smells in a good way, but the one, I'm like pointing like you all can see. So one of them bust open in the box and it smelled like some boy, I think in like middle school, and it was very off-putting. The smell's fine, but it just really reminded me of this boy who must have been mean or rude, or I don't know, maybe it was just the discomfort of being a preteen, which was real, not a trauma, but I know it's an example of how feelings and emotions can be tied to smells that you don't even realize it till you smell it. So in like middle school, I was what, 12 to 14, I'm 40, still right back there. It's weird, it's different. It's uncomfortable and it's surprising. If we think about kids with ASD, I mean, God, a lot of people, they don't like surprises. I don't like surprises, right? Even good surprises. I need to know what's happening next. So then the surprise, big emotional reaction can be such a surprise. On the left, this comes from Doctors Gottman. They're two therapists who really pioneered Gottman training, Gottman, and it's helping couples sort of resolve conflict. And this list came from them. These are other, remember I mentioned hungry, angry, lonely, tired as states of being that could be triggers. Here's a nice list that they put together. So feeling scolded. Remember, I mentioned those punishing practices could be triggers for a child or anybody who was experienced trauma that involved another person, potentially, right? So we want to be really thoughtful about how do we redirect and correct versus scold, judged. I have a very zero tolerance policy for gossip here. Tell people I'm not the thought police, but I kind of am the behavior police here. So once you can think your thoughts, but once it comes out of your mouth, it's now a behavior in the workplace, and we need to address that. Judgment comes a lot with trauma. So any of the ignored, unsafe, forgotten, frustrated, disconnected, trapped. This can happen with our kids with ASD. Sometimes they like to wedge in small spaces, or we engage in this kind of physical gross motor play. They could feel trapped physically and not know it, and we don't know it. And then there's this big explosive response that might take us by surprise, but they felt trapped and unsafe and out of control. I also want to mention trigger warnings. I'm seeing them more, which I really appreciate. And I've had some questions from folks, and so I just want to mention them. So they're often abbreviated on social media as TW. There's probably other I just don't know what they are, but I see TW. I know that means trigger warning. And that means, so if I say, let's say I was going to tell you one of my trauma stories or talk about it, I would say trigger warning. And then let's say I was going to talk about the, when I was stalked and the pug was involved in that animal abuse. I would say trigger warning, animal abuse, and intimate partner violence. That tells you some of those are the two things that trauma was surrounding. And so that tells the listeners that content is coming. And then you want to pause after it. Or if you're doing it on social media, hit a couple enters or like, what is it? Enter. Yeah. So that there's space, so that if a person clicks it, they're actively choosing to read, or you pause so that you're giving them time to like click mute I guess not mute, like click the X on the auditory so that they don't hear, or step away. Sometimes if I do a talk like for psychology, I will put TW right here and I tell them what's coming. And then I tell them that I will put another image like a green circle that means it's okay to come back so they can step away. But it's letting a person know what's coming so that you can choose whether you continue to listen and participate in this conversation. And you pick that, I pick that, oftentimes based on how I'm feeling. If I'm not, right, if I'm hungry, angry, lonely, tired, if it's content that's related to something I've experienced, I'm not in a great mental place, I'm probably going to step away. That's okay. Any questions about triggers? It's okay if there's not. And I find I'm checking in more frequently because of the content and because there's less engagement in the chat, which is okay. That's expected when the topic might be harder, and still wanting to be sure that folks know that it's okay to chime in and to check in with kind of how everyone's doing. Not everyone who experiences trauma goes on to develop a mental health disorder. So trauma, including one-time, multiple, or long-lasting repetitive events, affects everyone differently. Some people will go on to develop PTSD, some won't. So we want to be careful that just because a person experienced trauma, we are being thoughtful about how it impacted them and not doing the same for them that we would do for anyone else, right? That individualization is key and kind of what we rock at ABA. There also, it's possible that it could impact them, but at subclinical levels. So not enough to qualify as a disorder or a diagnosis, and it could still be impacting them. And it depends on many factors like the individual, the type of event, how old they were, the meaning of the trauma, and other social cultural factors. I'm also noticing that I am going over time. So I will pick up the pace and appreciate your flexibility. Remember, there's no CEs for this, so you're welcome to come in and out as you choose. It will be recorded, and I'll stop the recording after this one and start a fresh recording when we move on to the next one. There are different trauma-related diagnoses, and I want to just mention these, not because you're necessarily doing diagnoses, but if when you're doing a record review, you see these diagnoses listed, it may give you some information about their learning history, right? About their history. Acute stress disorder, this is a normal response to stress. It resolves within 2 days to 4 weeks after the event. So it doesn't persist longer. Those symptoms and behaviors do not persist more than 4 weeks after the event. It's a significant distress. That's normal, right? Sometimes patients will come for therapy and be like, you know, I'm feeling this kind of way after this. Yeah, that was traumatic. This is normal. I'd be more worried if you weren't having a hard time. PTSD, people are often familiar with. It stands for post-traumatic stress disorder. This is when symptoms persist past the 4 weeks from the event. So you do not diagnose PTSD until it is 4 weeks post the event. There's more symptoms. So like you have to check off 11 out of the list of 14. There are symptoms that overlap with other diagnoses like anxiety, psychosis, major depressive disorder. And there are different criteria for PTSD for children under the age of 6. There's also complex trauma, which is not in the DSM-5 yet. And many clinicians who practice with individuals with trauma do acknowledge that an individual who has experienced complex trauma, which means multiple traumas and often over longer periods of time, it looks different and treatment's different. And then those sub-threshold symptoms. So symptoms that occur and are disruptive and don't meet diagnostic criteria. And then co-occurring disorders. So substance use and abuse. ASD can be co-occurring with PTSD, right? So it doesn't just have to be one. I want to pause and do some square breathing together just as a regulating activity and to teach you something that might be helpful. So you start here. Anybody use square breathing? You can type yes or no in the chat. We start here. We breathe in for 4 seconds, hold for 4 seconds, out for 4 seconds, and hold. So we're going to go in through your nose to breathe in, hold it, Hold it. Out. Hold it. Hold it. Hold it. Right? This one looks like it's for a child, right? It goes in through the nose, you're holding it, out through the mouth and holding it. What this does is it trips your parasympathetic nervous system. It sort of tricks your brain into engaging that parasympathetic, that slowing system down. There's also ones like smell a flower, blow out a candle. If you practice mindfulness, I know somebody mentioned you do that at your organization. I'm a huge fan of mindfulness. You're in the moment and you come back to your breath. Your breath is always there. It's constant. Anybody heard any information lately or at all about ABA causing trauma? No? Okay. So I'm hearing a lot more of that. Yes. Yep. Okay. So a lot of adults with autism or older individuals, like individuals with ASD who have received ABI, particularly old school ABI, are reporting it was traumatic. That can be hard to hear as a BCBA, as an RBT. And maybe our first thought is, oh my God, that's not true. ABI is not traumatic. Do you remember that first slide that said trauma is as it's perceived by the individual? I am a believer of impact over intent. I didn't mean to hurt your feelings. And if you tell me I did, I don't say, no, I didn't. I need to hear what you're saying. And I am really sorry for hurting your feelings. It wasn't my intent, and I hear that it happened. I'll fix that. Sometimes we feel personally attacked and we say, that's not true, or that's not true. I don't believe that somebody can tell me that I traumatized them and I get to say, no, I didn't. I certainly say I did not intend to, and I hear that I did. I will modify my behavior immediately. And I also think that we need to think about some of the practices that we used to engage in. In the 90s, they were using shocks. Hell, there's still a place that's using aversives like shocks, withholding food, right? These things, what makes that not abuse in this context, but it would be abuse if I had been abducted. We've got to be really thoughtful about the way in which we are modifying behaviors by modifying contexts. The BACB is very clear that aversives are only used after all reinforcement strategies have been exhausted, and only with also reinforcement as part of that punishment protocol. It is hard to hear in the field. There are things that I did as an early career BCBA that are cringy now. I used to work on eye contact. God, that makes me cringe. We hear from adults with autism. Autistic adults tell us how uncomfortable that is. I'm not going to work on that then. It's not necessary. Or what else did I use? I did a lot more physical prompting, hand over hand early in my career. Ugh, I cringe at that. I don't do that now. I think it's important to hear that their experience of ABI may not be the same experience that you are giving. And it may be the experience they had. Our field is a science. It's always evolving. So sometimes when we hear something that's hard to hear, we might want to jump and say, that's not true. I don't know. I hear that's their feeling. Maybe that wasn't the intent, but impact over intent, right? I wonder, what are some occurrences in ABA, either current practices or historical practices you've heard about that could potentially cause trauma for some folks? Some that I mentioned was withholding food and water. It could be restraint practices, right? We are a lot bigger than our kids. How scary. Potty training could be traumatic, depending on how it's being carried out. Maybe more physical prompting, like hand over hand. I think escape extinction could potentially be traumatic. Yes, Erin. Yeah, certain extinction procedures for sure. Impact over intent. When you are small, you don't have autonomy in many ways. And bodily autonomy is one of the few things we should always have. Right? Remember when we were talking earlier and I was mentioning those certain groups that are at greater risk for trauma? Could some of that be because we've overtaught compliance so that they don't know that they can say no? Or that we've used physical prompting so much that they don't know that they have body autonomy? I'm not saying you're doing that. I'm not saying we're doing it now. I am saying it probably is still happening somewhere. And I'm saying it damn sure happened before. We can do better. And we are in many ways. And that's the beauty of staying connected to the literature and continuing to learn and to own our own missteps, which I own mine early on. I cringe at that. And I keep learning and doing better. Okay. So the trauma assumed practices, what can we do? This comes from University of Buffalo. So it's freely available. It's not about ABA, it's about social work, and they apply. Ensuring physical and emotional safety. So making sure that common areas are welcome and privacy is respected. Individuals are provided clear and appropriate messages about their rights and responsibilities. Individuals are provided significant role in their planning and evaluating services. So do they help pick their goals? Do we listen to assent, right? Look, some stuff, yes, we have to go all in on. But do we have to die on every hill, right? So I wanted to just sit in the chair. Do you have to if that's really causing an issue, right? So allowing choice where possible. Respectful and professional boundaries are maintained. That's key. Do I do what I say I'm going to do? And do I follow through with what I say? That's so key to show up and be consistent. Little things like frequently calling out as a RBT or even as a BCBA, that tells our families that we are not trustworthy. That does not create a secure relationship. And then when somebody fills in for you, that person feels extra trustworthy because they're making up for us being out. I'm not saying you can't be out, be out. And if you need to be out a lot, maybe modify your schedule so that it's not kind of calling out, so that it's predictable. Providing an atmosphere that allows individuals to feel valued, validated, affirmed with each and every contact with our organization and with each other. We hear concerns. We don't poo-poo them. We validate them. These are organizational steps. And I hope as you're thinking about your organization, that you're seeing ways that you do this. And that as an RBT, as a BT, as a para, as a DSP, as a BCBA, BCABA, whatever, that you are thinking about how your behavior supports these. And if you're looking and you're saying, man, I think we can do better in these areas, I encourage to reach out and start a conversation about how this can be implemented in different ways in your organization. I think we do a pretty good job of this, and I'm always looking to do better because other people have great ideas. Key components. So again, this is trauma-informed care, but I like trauma-assumed, but this is such a great graphic, again, from University of Buffalo. So the approach needs to be infused into everything. Everything. It's not just on trauma day, right? We've got books in our lending library that help staff work through stuff. We've got, we talk about trauma. We've got our EAP. We do trainings. We, if a child pulls away, we take that as assent withdrawal. We don't, compliance is not always important. Staff at all levels work on their behavior. It's not just for RBTs, it's for everyone. It involves vigilance in anticipating and avoiding institutional processes that are likely to re-traumatize. So I think potty training that Amanda gave is a great example. We've got to do different, what do our potty training or feeding or changing diapers? What's our policies there? Demonstrating greater awareness of the impact of trauma on all individuals. Changing the thinking from what's going on with this person to what happened to the person. That's different. It hits different, right? Like, what's the matter with them? Versus, man, I wonder what happened, right? I lean into that. Acceptance that trauma influences the effectiveness across all services. So when an individual is in the middle of a re-experiencing episode, they are not able to learn, not because they're not wonderful. They're in fight or flight. That frontal lobe has gone offline. And if we are constantly going into that state, we are really not learning. And if they're coming to ABA to learn, and we are triggering them to go into a psychological, biological state where they can't learn, we are cutting ourselves off at the knees. Solution-based approaches. So if we see something's not working, let's change it. There's no reason to like stew in it. Let's just make a change. And then recognizing that trauma is pervasive. This is not one person in a million, right? That's that assumed part. Community care is key. I always say I have a beef with, and then I say, I don't know if people say that anymore. Now that that's fused, I keep saying it. Self-care is not enough. It's not. Self-care is like saying you just didn't take care of you, and that's why you're not healthy and well. Bullshit. There has to be a community of care. So the EAP, time off, flexible schedules as much as possible, supervisors that are checking in on you, talking about trauma. There has to be systems of care that allow you to engage in self-care, right? Self-care is not enough. There comes a point when we need to stop pulling people out of the river. We have to go upstream and find out why they're falling in. The system of care is community care, I call it, is finding out why they're falling in. Got to look at that. Everyone, right? Families, staff, self, clients. A community of care is one that cares about the entire community and has systems in place to help the community be healthy and well. Having long hours and inflexibility in your schedule so that you can't make it to a therapy appointment or a doctor appointment is not community care, right? No amount of self-care is going to make your blood pressure go down or make you process trauma, right? We need those appointments, and community care is being able to get to those appointments, having health insurance to go to them. Okay, road to trauma-informed care. So these also come from University of Buffalo. They have great stuff on their website. There's also for pediatrics, specifically National Child Trauma Network, NCST. I'm missing an S in there. National Child Support Trauma Network, NCST. So address potential maltreatment or re-traumatization policies and procedures. Let's relook at them. Let's modify what's not working. An internal trauma team. This is something that we don't have at Del Mar and that I really would like to do as there's more and more folks getting interested in this area. It generally is just me, and then I have another mental health colleague that helps. And I think I need to broaden what I've worked on is broadening my sense of a trauma, my definition of a trauma response. It's not just me as the mental health clinician and the other mental health clinician. How can we broaden that trauma response? It's not just the talk therapy of processing it. And so that's something that's one of my Q1 goals. And I'm saying it here for accountability. Check back in with me and see how I'm doing. It ensures administrative commitment. So it has to come from me as well and from anybody that's leading your organization, not just the mental health folks. There's at least an introductory training and discussion to staff of all levels, includes providers and provides training or planning and evaluations of services. So like the staff receiving service or the kids receiving services have a say in what this looks like. And then early and respectful trauma screening. So that's part of our intake process for all disciplines. It didn't used to be part of our ABA intake and speech and OT, and it is now. I do want to touch on self-care because we talked about some tough stuff. Make sure you're taking care of yourself when you're watching trauma webinars or reading about trauma or hearing about trauma. Not this alone, this in conjunction with those other community care practices. Remember all the different areas of self-care: physical, emotional, social, spiritual, work, financial, environmental, personal, all of them are important. And making sure that we're pouring into all of them as needed so that we can stay healthy and well, so that we can be regulated and able to notice a potential trauma response from another individual, right? Because if I'm wound up and I'm not well, I'm not attending as well, and I'm more likely to miss it. Some common trauma behaviors might be pulling away, tears, screaming, physical aggression, having like urinating or defecating in response to a behavior, right? It's not like having an accident necessarily, although that could be, but they tend to be really big behavior. It's fear. I mean, it's fear. You can see it in somebody's eyes. It's fear. And it can occur in smaller bits, right? Like a precursor, I call them precursors. I call them pink flags, right? So an early indicator something's off is pulling away physically. Doesn't always mean trauma, but it means they're not feeling whatever I'm doing. I need to back up and give them space. I don't go after them. Even playing chase sometimes. We have a new little gal that's receiving services and we're following after her to like really keep her safe, to just monitor her. And I'm wondering if she feels like we're chasing after her, and that can be scary because we're big. And so needing to modify, and this was just this week, PS, this is not like early Becca, this, I noticed what we were doing. That wasn't the intent, but it's impact over intent. And so can we sit in the hallway and watch her pace to keep her safe while not following her so she doesn't feel chased? Okay. Thoughts, feelings, reactions. I'm actually going to stop the recording now so that if there are questions, you can feel comfortable asking them without it being recorded